Good evening. I am Dr. Ajinkya Nanavre from Emcure Pharmaceuticals. I welcome everyone to yet another session of the No Thrombosis workshop in acute ischemic stroke. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. In the previous workshops, we had a pleasure of engaging in very unique and interesting case discussions, and we are looking forward to have another enriching discussion today as well. And it is my honor to introduce our faculty for today's session. So let me just share my screen. Yeah. So I first welcome our course director, Dr. Subhash Kaul sir. Sir is senior consultant and stroke specialist at KIMS Foundation and Research Center, Secunderabad. Sir has been faculty for 27 years at Nizam Institute of Medical Sciences, Hyderabad. He has been a former professor and head Department of Neurology and Dean at NIMS. Sir has more than 120 publications in national as well as international journals. He has been principal and co-investigator of several national and international projects, including the largest single center Hyderabad Stroke Registry, which was funded by the ICMR. He has won the State Teacher Award by Telangana government in 2017. Sir has been a past president of AP Neuroscientist Association, Indian Stroke Association, and Indian Academy of Neurology as well. Welcome, sir. Welcome to No Thrombosis.
Thank you.
Then I welcome our first moderator for today's session, Dr. S. Meenakshi Sundaram sir. Sir is senior consultant neurologist at Apollo Hospitals, Madurai. He is a recipient of Gold Medal and Best Outgoing Student Award for the year 2000 from the NIMANS, Bangalore. He has been over 20 years of experience and in neurology and more than 36 publications in various national and international journals. Sir has presented many papers at various prestigious national and international forums and received the Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology in Lucknow 2002. Sir has been a principal investigator for many international trials, such as trials for refractory partial epilepsy, stroke trials, acute stroke intervention trial, and Parkinson's disease trial. Sir has been an editor of the South Asian edition of the book Practical Neurology and also contributed to many other books on neurology. Welcome, sir. Welcome to No Thrombosis workshop. Then I welcome our second moderator for tonight's session, Dr. Umer Karadan sir. Sir is a HOD and senior consultant neurology and interventional neurology at Baby Memorial Hospital, Calicut. Sir has been awarded by IMA Kerala State, Kerala Association of Neurologists, and also by the Government of Kerala in recognition of the Nipah outbreak containment. Sir has a certificate of expertise, which is a special appreciation from Pub Index International. Sir has 15 different memberships like Indian Medical Association, Kerala Association of Neurologists, Indian Academy of Neurology, Indian Stroke Association, World Stroke Association, American Academy of Neurology, European Academy of Neurology, Movement Disorders Society of India, International Movement Disorder Society, etc. Sir is a president of Samarpanam, an international charity organization from 2016 till now. He has also been a past president of Calicut Neurological Society, executive member of Neurological Society of India, and he is a part of total 37 social services and health awareness programs. Sir was a principal investigator of more than 12 trials and studies like IRIS TNK, Interact2, and Inspire. He is a co-principal investigator for 5 studies like VitaTop, TNK TPS study, and also part of 4 ongoing studies. Sir has given more than 25 visual media and press talks. Almost 12 workshops Sir has attended, and more than 285 webinars and expert talks were given by Sir. Sir has more than 28 publications in various national and international journals as well. So welcome, sir. Welcome to No Thrombosis workshop. Then I welcome our first speaker, Dr. Prayag Makwana, sir. Sir is a consultant neurologist and stroke specialist at Makwana Neuro and Stroke Clinic, Surat. He has a postdoctoral fellowship in stroke and neurointerventions from Rajagiri Hospitals, Kochi, Kerala. Sir has 9 publications in national and international journals and 2 posters and 1 paper presentations at various conferences. Clinical and procedural skills include angioplasty of carotid and vertebral lesions, carotid stenting, vertebral stenting, intracranial vascular angioplasty, transcranial Doppler studies, endovascular coiling of aneurysms, etc. Sir has also expertise in headache, epilepsy, demyelinating disorders, CNS infections, neurodegenerative disorders, Parkinsonism, and myelitis. So welcome, sir. Welcome to today's no thrombosis session. Then I welcome our second expert speaker for tonight's session, Dr. C. Ramesh, sir. Sir is a managing director and consultant neurologist at RNC Super Specialty Hospital, Hyderabad. Sir is a DNB General Medicine. Sir has passed DNB General Medicine 2013 and DM Neurology in 2018. Sir has working as a consultant neurologist from 2018 till now, and he has more than 3 publications in various national and international journals. So with this short introduction of everyone, I would like to hand over tonight's session to Dr. Kaul sir for his opening comments and the context setting. Dr. Kaul sir, over to you.
Yeah, thank you, dear friends. I think I welcome you once again in this recurring meeting every month, in which the main aim is to share the individual cases and the unusual features of those cases, which usually are not captured by big studies. You know, patients come to us on a case-to-case basis, and each case is different. And that is the whole aim, and we have been doing it quite successfully since some time. So I welcome the chairperson, Dr. Umair, and I think we'll wait for Meenakshi also. He'll join in the meantime. And also
Yes.
today's speakers, Dr. Prayag and Dr. Ramesh. So can I request Dr. Umair to take over and invite these speakers for today's presentations?
Okay, sir. Thank you. Thank you very much, sir. Good evening, everyone, dear friends. Today, I think, as sir was mentioning, this is one of the session on the no thrombosis workshop. So we have our colleagues here. I think Dr. Prayag will be speaking on the first case. And I think without much ado, I think let's go to the first case, and after that we can have the discussion, because Subhash Kaul sir is there, and I don't think we need anyone else to talk or debate. And I think he's the best person. And we think we can just compliment if at all anything is required. Thank you, sir. And over to Dr. Prayag now. Thank you.
Am I audible?
Yeah. Please make it slideshow.
Yeah. Good evening, Subhash sir. It's really nice to see you and Umesh sir and everyone. I'm basically practicing at Surat, Gujarat, and stroke and neuro interventions is what I am really passionate about. I don't have much slides. I'll just have a small case, and we have seen similar cases. We are seeing similar cases. We'll just run through the slides. So it was just a 57-year gentleman with a left-sided upper limb weakness, and it was monoparesis and facial weakness with slurring of speech. He was a known case of hypertension. There was mild giddiness, and there was some breathing difficulty, but that was not because of stroke. And he was a known case of hypertension. BP was in the more than 185, around 191, 210 systolic. And there was a upper limb weakness. Upper limb weakness was significant. And we did, just like patient had come in window period, and because MRI was there, so we did MRI. Otherwise, most of the times we prefer plain CT and CT angio. So MRI was showing right MCA infarct, and in angio it didn't reveal any large vessel occlusion. So in such cases, like we all know, we started a Lobet infusion, and we tried to, once the BP came around 180 systolic, then we went ahead with intravenous thrombolysis after taking written consent and after explaining to patients' relatives regarding the risk of bleeding. And once they gave consent, we proceeded with intravenous thrombolysis, and NIHS was around 6. So there was this infarct. It was small infarct, and I don't have angio images, but it was acute infarct. So we give 0.20 mg per kg stat after BP control. And patient was then, just like our stroke protocols, was monitored in ICU, and we did a repeat. There was no other headache or convulsion or any vomiting or seizures. So we didn't feel the need to do a repeat CT urgently. So once in 24 hours, we did one check CT, and there was no bleeding. So we started on antiplatelet medicines, and subsequently patient was shifted to ward and then discharged. So there was some residual deficit of facial palsy, and he's still coming to follow-up. We started on a single antiplatelet and statins. We tried to find any other etiology, but it was mostly atherosclerotic. Echo and Holter was done. So there was no evidence of any cardioembolic etiology, at least on SANE, because already the etiological factor hypertension was there. So we managed conservatively medical management, and then we are doing follow-up in neurology OPD. So that is the crux of the case. I mean, it is not like any atypical presentation. And I'm sorry, I had a very short time to find. So this is what this case is about. So last like 3-4 years, I'm giving tenecteplase and also altiplase. So it's, but being a neurointerventional stroke specialist, my experiences with less time involved in giving less time, and we can shift directly to cath lab. So this is all about it.
Yeah. What could be a very nice case, Prega? What could be the reason for the breathlessness? Is it associated or is it something else?
No, so it is not associated. That was patient was feeling breathless, but we otherwise saturation was fine, and the patient was hypertensive. So maybe some anxiety might be there, but otherwise his chest was okay. There was like no other. Tachypnea was also not there significant.
Yeah, because sometimes the pulmonary embolism and
correct, sir.
Whale can have an infarct there as well as infarct the lung.
Yeah.
And similarly in ischemia, an unstable angina or MI can also present the same way. That could trigger or embolize. One clot must have gone up and dissolved, and this causes a lacunar stroke. Very unlikely, but I'm just speculating all this.
No, definitely.
Was the breathlessness after thrombolysis or even before thrombolysis he came?
No, there was some breathlessness, but it was not after thrombolysis. Patient actually settled down once BP was controlled. And there was no breathlessness.
Now his MR angiogram was normal, the vessels were normal?
Yeah, no large vessel occlusion.
And the carotids were also normal?
Yeah. There was no any not even moderate stenosis was there.
So this is technically this will go into the ESUS, embolic stroke of unknown source.
Yeah.
Because it is little bigger than lacune. Size wise, it's bigger than lacune.
Bigger.
Right?
Yeah.
And we don't have any. Technically speaking, when we say atherosclerosis, we say it should be more than 50% of stenosis, which is not there.
Yeah.
So eventually, I think you will need in follow-up to still look for TEE to see whether there's any underlying
Correct, sir.
which is part of the workup for that. Otherwise, it's a very straightforward routine case with a good success. That's what we want finally.
Yeah, sir. So patient had an uneventful stay after thrombolysis.
Yeah.
Everything went.
I think we should have seen the MR angio, especially intracranial, the ICAD, whether there's any intracranial atherosclerosis there, because most of the time MRI may not pick up all these things. Sometimes it can overestimate, or sometimes it won't be seen.
Yes. Sir, because I'm more into neurointervention, I specifically see for ECAD and ICAD, because our Indian population, Asian population, the incidence of ICAD is very high.
Yeah. And I think CT with the CT angio would have been...
angio, correct, sir. Correct. CT angio, yes.
What was his age?
57, sir.
Okay. Yeah.
Holter, did you do the Holter or other work?
Patient was already in ICU for around 2 days.
Echo and normal. Echo
was normal. Patient was already in ICU only. So
this is an in-hospital stroke.
Yeah.
So it is very likely that this could have been a pulmonary embolism. I mean, pulmonary embolism, and one clot must have gone to the, to the cranial circulation. Yeah. So the breathlessness, there is a little odd man in this.
Yeah.
And the tenecteplase would help the pulmonary embolism also.
Yeah.
Yes, it will help both the ways.
Yes. Yeah. So I think that's a good case. Yes. But what is your how often do you get to do mechanical thrombectomy? How common is that problem in your area? Once a month or once in a week? How frequent is?
Sir, the patients come, but affordability issue remains. Now patients come in window period, sir. It's like the numbers have increased, but around 2 to 3 patients per month, something like that. Endovascular thrombectomy.
So do you believe in the bridging? You do first IV, or do you believe in direct? To which group you belong? Because there are 2 groups. No, one doing direct and one
bridging is important, because whenever the patient comes, it's almost like after 3.5 hours to within 4.5 hours. So it's what I believe is, at least we should give IV thrombolysis, because we need data about the aortic arch, and in some patients it is difficult to do endovascular thrombectomy because of arch. We have seen many carotids with loop, 360-degree loop. So it's better to at least give them IV thrombolysis, because it is difficult to predict that which patient is going to have a successful thrombectomy. Sometimes after even 3 tries with stent retriever, 3 tries with aspiration or combination also, it is difficult to recanalize. So at that time, we also know that even doing 3 passes of thrombectomy, it will at least take 30-40 minutes. So it should not be like we are in a no man's land. We are not giving thrombolysis, and we are not able to get a successful mechanical thrombectomy. I mean, TICI 2B3A recanalization. So it's at least so I believe that whichever patient, we should at least give thrombolysis. We should thrombolize, and then we should proceed.
As of now, you are giving IV thrombolysis only up to 4.5 hours, or not more than that?
No, not more than that.
Because now some people have extended, if they have got the artificial intelligence software like Rapid and all, they are going even up to 9 hours. But most of us don't have that software still.
Yeah.
It's software.
No, sir, 4.5 hours is the cutoff.
Yes, sir.
But how much is the stroke awareness in Surat?
Sir, there is a Surat city awareness is there, but what happens is, to be very frank, these patients have comorbid. Most of the patients are visiting their physicians for their comorbid diabetic, hypertensive, regular checkups. So their primary source point of contact is their MD physician who is the near or general physician. So what happens is there is a significant delay in patient in reaching to a thrombectomy ready center like US. So they know that, okay, stroke is there. There is one injection that has to be given. But because the point of contact is more than one, general practitioner, then medicine, and then going to a neurologist. So I think that makes things difficult. Like, time is brain, and we miss out on that. But there is definitely awareness for acute IV thrombolysis. Endovascular, definitely it is less.
I remember I have gone many years ago. I think it must be at least 15 years ago. I have been to Surat for a stroke awareness talk. I think Dr. Anirudh Apte was there.
Yes, sir.
He organized some CME. Shakir Hussain and myself, we went to Surat, and that time also there was this. Surat is a very important town. It's a very business town.
Yes.
I think affordability should not be such a big problem. What do you say?
No, affordability issue is not that big a problem. At least in city, yeah.
How is it in your place, Dr. Umer? How much is the stroke awareness?
Yeah, it is very much is there, sir. Because
I've been working quite hard in Kerala so many years.
Yeah, and of course we get a lot of stroke cases for IV, and maybe 1 or 2 per week. Sometimes even 2 cases per day. Sometimes. Or for mechanical thrombectomy, and we have done up to 5 IV TPA in 24 hours.
Oh,
5. TPA or 10, and the 10 tenectors, because earlier we were using that, and of course of late we have switched to the new molecule. And so the problem with the this IV medication is that sometimes there can be a tandem occlusion. Once there is tandem occlusion, we may have to do a proximal stenting of the carotid artery. In those cases, bridging may not be a very viable option. I mean, it's an option, only thing that we may, sometimes if it bleeds and we have to stop the antiplatelets and the stent may get occluded. So it was a hyperacute, maybe within 3 hours and all. If we could do the angiogram thrombectomy within minimum time, maybe 30 minutes or 45 minutes, we would try to avoid.
No, how do you tackle with those tandem lesions? How do you tackle? What do you do?
So we do the intracranial first. I mean the M1. Suppose the M1 occlusion.
M1. But the tandem lesion is still there.
Yeah. Then we pass. We pass the guiding catheter, pass the lesion.
Yeah.
Do the procedure, intracranial procedure first. The suction thrombectomy or aspiration.
But what do you do with the proximal lesion?
And proximal we dilate and we put a stent. Sometimes we put a stent, suppose if we just do angioplasty, and maybe after a week we do a different procedure.
Once intracranial is done with, we see if the stenosis closes or it remains open for around 20 minutes, 30 minutes. If it remains open, then we take the carotid lesion in the next sitting. But if it closes, then we have to do rescue stenting.
So sometimes there can be bleeds also, no? Once we give double antiplatelets.
Yeah, so we have to load with dual antiplatelets.
Sir, recently we had a patient. Sir, we had a patient with the M1 occlusion, and we did with ICAD. There is a M1 occlusion as well as the ICAD. So we tried the penumbra aspiration many times, but each time it was getting re-occluded. Then we did an intracranial angioplasty. In fact, the patient had received IV also, IV 10 tenectors also. Then we thought that because each time we passed the stent system, it would re-occlude. So we had to do intracranial angioplasty followed by double antiplatelet. Then we found that next day he had a contrast as well as bleed. Both were there in the frontal lobe. But the bleed was not, it's only mild to moderate. So we continued with the double antiplatelets. In spite of there is a bleed, nothing happened. After we repeated the CT after 3 days, 1 week, 2 weeks, the bleed came down to a normal size, and he improved dramatically. The hemiplegia, FS, everything improved. And even though there is a bleed in the frontal lobe, which is not causing any mass effect, no intraventricular extension, there is no subrectal bleed, we continue double antiplatelets in spite of there is a bleed. And by 1 to 2 weeks is fully normal, and on follow-up, there is no deficit at all.
Doing pure angioplasty without stenting does not work. It gets reoccluded, right? I mean, because that way we could avoid double.
Yeah, most of the times. Yeah, most of the time, sir.
Yeah, that's right.
Yeah.
Okay.
So these are the real difficult questions, and these are where we have to work as a team. And I think that's very nice to know that you are really doing state-of-the-art work.
Yeah.
These are challenging patients.
Yeah.
How often have you got dissection as a complication of mechanical thrombectomy? Does that happen or not really?
No, sir. Very, very extremely rare. Because if you are gentle with the vessels, there is nothing will happen. And regarding that, whether we can do cheap also, because we can, with the same catheter, we can do 3, 4, 5 times. So for the poor people, we can do at a lower cost. And sometimes if there is a basilar occlusion, we just aspirate. So we don't have to use a stent. We can use the old material. Old material is not safe. Of course, it's not safe. But if there is a necessity, or if there is a real compromise, if there is a challenges, economic challenges there, we can always go to the occluded area. We can put an aspirate. We can just aspirate. Most of the time, it can. So it's a soft cloud and all. It would come out. So even with a very low, cost, we can do a thrombectomy also, especially in the basilar or in the ICA. And thirdly, if the aortic arch is very, tortuous and all, we can go through the radial route. We can go through it. So I think we should do that also. And there are people who can go through the anatomical snuff box also. So at least try to do in the radial or in the brachial route, so that the time can be saved. Rather than struggling at the aortic route, we can go through that. There is also another viable option.
It's very nice. So thank you very much. I think that was very good case. Yes. We had a good discussion. We can move to the second case. Then Dr. Umer, Dr. Ramesh can present.
Yes, sir.
Thank you, Dr. Makwana.
Yes, sir. Sir, Dr. Prayag had some stroke emergency, so he had to leave this meeting. So, Dr. Ramesh, sir, can you share your screen?
Yeah. Dr. Ramesh, please start.
Sir, good evening, sir. Sir Kaul, sir, good evening.
Good evening, sir. Good evening.
So, my case is very interesting, and I started giving some insight into the anticoagulation along with the patient who was an anticoagulation when presented with stroke, what we need to think, and is the guidelines what is saying in the guidelines is INR value and APTT value. So these things I will go through. So what are the guidelines says regarding the anticoagulation use in the stroke? IV thrombolysis may be reasonable in patients who had a history of warfarin use with INR of less than 1.7 and PT less than 50 seconds is the level B evidence. The safety efficacy of IV thrombolysis in acute stroke with a clinical history of potential bleeding dialysis or coagulopathy is unknown. If the bleeding potential is unknown, still you can consider IV thrombolysis on case basis. The safety efficacy of altiplase in acute stroke with a platelets of less than 1 lakh with APTT more than 1.7, PT APTT more than 40, INR more than 1.7, PT is more than 15 seconds is unknown. So in these cases, IV altiplase should not be administered, is more harmful according to the guidelines. In patient without recent use of oral anticoagulation or apparent treatment with IV altiplase or tenecteplase can be initiated before availability of coagulation test, but should be discontinued if the INR comes more than 1.7. So my case is a 72-year female patient who underwent mitral valve replacement 20 years back, and she is an anti-coagulation warfarin. She presented with the left hemiplegia. There was no movement, absolute no movement at all in the upper limb and lower limbs. And the NHS score was 10 and presented after 3.4, 3 hours 45 minutes after the stroke onset. And we sent all parameters, and we counseled regarding the options of thrombolysis and thrombectomy. And regarding the prognosis, we told to the patient attenders, I am reluctant to give because INR is more than 1.7. This was my second case where I given IV TPA more than 1.7. Previously, it was a pontine stroke where INR was 1.9. And I given this even though INR is 2.2. And they opted after discussion regarding the prognosis. And initial CT was normal when I given TPA. This was a MRI after TPA, after 24 hours of TPA. Patient improved within 4 hours, complete from the 0/5 to 5/5. So this was the MRI after TPA. So there was a infarct in the subcortical infarct in the right MCA territory. And there was a tiny infarct in the upper cortex region. So this is MR angio. There is a recanalization, probably recanalization of the right MCA. So what are the literature saying regarding the WARF patients on WARF and TPA? So apart from the guidelines, what are the actual figures where the patient present with the stroke who are using on warfarin, and how they are proceeding with the TPA. So in the guidelines, what we are seeing, there is a inclusions and exclusion criteria. These are taken from the scientific rationale for the inclusion and exclusion for the intravenous alteplase in acute stroke. So this was published in 2016 Stroke Journal, where many of the neurologists, they consider many studies, they included what are the inclusion criteria before giving a IV alteplase or tenecteplase, and what are the exclusion criteria. In these, I have taken where patients who are on warfarin and how many patients actually presents with stroke. So this is the data where this observational study, the data from American Heart Association. These studies get with the guideline stroke registry where 23,000, more than 23,000 patients with acute ischemic stroke and with INR more than less than 1.7 treated with IV TPA, almost in a 1200 plus registered hospital from April 2009 to 2011. So they looked into the symptomatic intracranial hemorrhage, secondary outcome points like life-threatening and serious systemic hemorrhages, or any other TPA complications and in-hospital mortality. Almost in this study, they found out that 7.7% who had on warfarin, they presented with a stroke, and they given a alteplase. So this is another study where the safety of intravenous thrombolysis for ischemic stroke patient treated with warfarin. In these, they analyzed almost 45,000 of patients treated with IV TPA enrolled in the safe implementation of thrombolysis in a stroke, SITS, International Stroke Thrombolysis Registry, out of which 768 patients had a baseline warfarin treatment with INR less than 7. They looked into the outcome of recanalization, mortality, functional independence at 3 months. In this study, they found out arterial recanalization by the computed tomography or magnetic angiography, they tend to be higher in warfarin treated group who has previously on warf, and warfarin treatment with less than 1.7 did not increase the risk of intracerebral hemorrhage or death and had no impact on the long-term functional outcome in patients with the TPA for acute ischemic stroke. So Canadian study, these data as actually they have a data patient on discharged warfarin. In a HASTE project, that is Calgary, in the Calgary from the June 2012 to June 2015, out of which 350 patients treated with intravenous thrombolysis, where 39 patients had a warfarin on treatment. So actually, why do warfarin treated patients have a stroke? So most probably it is a high rate of non-compliance with the drug. Most of these discontinued rates vary from 10 to 33%. It is possible that warfarin treated patient we see with a low INR is actually more non-compliant than any other else. So what is, if the patient has a high INR, what will usually do? What about the one with the high INR? Logically speaking, where patients with high INR should not have a clotting, should not have been clotting. So mechanism of action may be a non-compliant in the preceding just 1 to 2 days or preceding week, or patient with a lupus who had an inaccurate INR recording, or in cancer patient who had a therapeutic, even though the patient have a therapeutic INR, still they clot. So why INR more than less than 1.7 is taken into the guidelines? According to the guidelines, with a high INR thought to be attributable to the medication, not any other causes like liver failure, sepsis, or non-medication coagulopathy. They are not taken into the guidelines. So WARF with the TPA, where a high INR. So no trials looking at the patient with elevated INR receiving a TPA. There are almost 115 cases of WARF treated patient with more than 1.7 INR given TPA. Only one had developed intracerebral hemorrhage. So 138 patients with non-WARF induced high INR treated with TPA has been also reported. There is no difference in outcome where drug-related increased INR or non-WARF cases also. So in this study, they even though the INR, there are case reports where WARF or without WARF who had a high INR value, still they didn't have a much intracerebral hemorrhage. So how many WARF treated patients have still actually high INR? In a registry, GWTG, get with the stroke registry, where less than 10% had a more INR value. SITS registry, almost 30% had a more INR value. HST study, almost 8%. So almost 8 to 30% of patients who had a stroke on WARF, who had on WARF, had actually stroke with a high INR of more than 1.7. So what about the novel oral anticoagulation? Novavax target individual clotting protein. Example, dabigatran, rivaroxaban, apixaban. They do not require extensive monitoring or individualizing the doses. So dabigatran and apixaban is more effective than WARF at reducing the risk of stroke, especially in atrial fibrillation patient. Have reduced serious bleeding complication when compared to the WARF. They had a less bleeding risk. So only dabigatran has a reversal agent. So it is safe to give a reversal agent before thrombolizing. So if you look into the data where patients are Novavax who developed the stroke, there are few studies in this area because Novavax use is less common compared to the WARF. So one pilot study has been shown no difference. Recently, it is echoed in the recent preliminary findings of GWTG study, where the sub-study has used Novavax. So what about Novavax? Patient is on Novavax and those patients present with stroke, what should we do? Should we thrombolyze or should we wait? INR is calibrating vitamin K antagonist. This is not useful in the patients who have Novavax. The PT is also cannot be used for the dabigatran as it is a thrombin direct inhibitor. Can be used APTT in these patients. If the more than 40, it is contraindication for the TP. Summary: between almost 2 to 11% of patients who had a stroke eligible for TPA, maybe or WARF. If INR is less than 1.7, there is no increased risk for the poor outcomes. If INR is low in the warfarin treated patient, most of the time, the case report of patients with high INR receiving TPA has not shown a negative outcomes. So due to the insufficient data, safety and effectiveness of IV TPA in patients with INR more than 1.7 cannot be confirmed. Warp-treated stroke patients with INR more than 1.7 should be individually assessed for an appropriate IV thrombolysis. Cases like these provides important information regarding the IV thrombolysis in high INR cases beyond the level recommended by the current guidelines. Points out the direction for further studies may ultimately benefit more warp-treated patients. INR administered within 3 hours doesn't significantly increase the risk of intracerebral hemorrhage. So some warp-treated patients with more INR 1.7 should be case-based, individualized. The level of evidence is not high, and there should be a multi-center randomized clinical trials in certain group of patients like valvular heart disease, AF patients are required to further verify these hypotheses. Thank you.
Thank you, Dr. Ramesh. Dr. Umair, you have any comments?
Sir, we have many patients with high lacunar strokes, multiple lacunas. Every time, maybe he had come twice. One patient had come twice. He was on valve, mitral valve. He meticulously monitored the PTINR. There is no deficiency or non-compliance from his side. And his carotid were normal, his heart is normal. Once his INR was 4.2, and still he developed a mild cerebral stroke. So I don't think that, it's not the non-compliance per se. There is something else also operating. So what is your opinion, sir, on this sort of high INR getting strokes?
Ramesh, you surveyed the literature on that, no? High INR getting strokes.
Yes, sir.
So what does the literature say? I have also faced this difficulty sometimes, as Dr. Umair says. Is there anything in the literature, the mechanism why people with high INR get strokes?
They didn't find anything, sir. So INR usually monitor the VARF. Some patients VARF still had a struck valves sometimes. They usually tend to embolize in those patients with most probably the surgery, the mitral valve surgery is long duration. Most probably this patient had almost 15 to 20 years back, she had underwent surgery. The literature, I didn't find specific, this might be, even though high INR causing the stroke.
No, because we see it sometimes, as you rightly say, we sometimes see there is not a one-to-one correlation between the INR and the tendency to clot. We see sometimes, we see on the both sides of the extreme. We see patients, in spite of high INR, they get ischemic stroke. In spite of low INR, they get bleed sometimes.
Yes, yes.
In fact, most of the people who have got bleeds, their INR are not high. Their INRs are normal. So there is this is not a very accurate measure. It may be accurate in about 70-80%, but in 30%, and really we don't know the reasons. There must be some biochemical mechanisms which we don't understand.
Yes, sir.
That is why sometimes what is even in the latest guidelines also they say that if a patient in spite of normal INR, this has been mentioned in terms of in patients with valvular heart disease like rheumatic mechanical valve, that if in spite of normal INR, you are allowed to add aspirin. Normally they don't allow aspirin, but they say that in case, rather than saying you further increase, they say that you can add aspirin. I think beyond a point, just increasing INR does not help. And I think this area nobody knows. This is a difficult area. But the question is very interesting, that can we have the guts to thrombolize? I mean, I would be very afraid on thrombolizing that patient. But many of the things we do sometimes by chance or in ignorance or in serendipity, and retrospectively you find, for instance, I have this is a very strict guideline that thrombocyte count, platelet count should be at least 1 lakh. Although most of the guidelines have been relaxed now, this 1 lakh guideline has not been relaxed. If you read today also, it says 1 lakh. But many of these patients, when we have done the CBC and we have thrombolized the patient, by the time the CBC comes, the platelet count is 50,000, 70,000, and they have not bled. Although the guideline says 1 lakh. But once you look at the retrospectively, the thrombocyte count is less than that. In fact, I'll tell you some more thing. I have seen some patients who have been thrombolized who even had a mild sulcal bleed also, which was missed initially. There was a ischemic stroke and there was a sulcal bleed also, and they were thrombolized and they became better. So I think there is not a, if you actually look at these patients, it does not mean that these patients will definitely bleed, but I think it is for the sake of safety. For the sake of safety, we are extremely cautious. And for being extremely cautious, some of our patients, may not be getting the benefit of thrombolysis. So it's a cost-benefit ratio. So I think, but still, Ramesh, I think, you have done something which I would be afraid to do.
I had a previous experience where the Pontine impact, where INR was 1.9. Still, I given the 2.2.
In fact, one day I was so.
I thought at that point, actually, for the valvular heart disease, the mitral valve or aortic valvular heart disease, they usually kept INR more than 3 at 2.5 to 3. Yes. So I thought that 2.2 still had a more thrombotic risk, and then I given that in that case.
No, that is true. But here the risk was giving a TPA may cause more bleeding. But you took the consent and they were ready for taking the risk.
Most probably the bleeding complication, if you look more of microvasculopathy, where I have almost I given 100 plus cases thrombolysis, with especially tenecteplase, where in my area, the middle class, lower middle class, the alteplase cost more, and I usually tend to give a tenecteplase more. So I had only one case bleeding. Apart, all other cases are recovered well. They are fine. So one case, the old age factor and high BP at the presentation. Previously, long high range of BP might be causing a vasculopathy. At the cerebral vasculature might be a bleeding risk in those patients.
No, you're right. These are arbitrary guidelines. These are arbitrary guidelines. These are, they have just selected this figure based on some data, but this is very arbitrary. A patient can bleed even if he has 1.6, and the patient may not bleed even if it's 2. This is arbitrary, but then that's how we learn. But still, I think if the patient is very keen, we have to tell him that this is the risk. And fortunately, our patient was lucky and he recovered also. What is your experience in this, Dr. Umair? Have you ever crossed this red line of 1.7?
No, sir, we haven't. But I think in this case, the right M2, one of the the superior deviation is blocked or getting blocked. Would you just go back to the MR angio?
Yes, sir. Yes.
Because compared to the inferior trunk, the superior trunk seems to be narrow in caliber with the poor flow.
This one.
Yeah, can see that compared to the on the left hand side and the right hand side, there's a poor flow. One of the maybe the superior. I'm not very sure because maybe the superior or inferior. But the infarct is on the parietal as well as in the infarct in the periventricular,
Inferior
mainly in the inferior.
More of the inferior.
Yeah, because there is a cortical, so watershed infarct in the cortical territory in the parietal region as well. So probably there is a thrombus in the M2, and that would have been thrombolized by your IV. But we would do maybe a mechanical or maybe a local intravascular thrombolysis there with the 1 milligram of this thing. The tenectase there, 1 milligram or 1.5 milligram. I mean, that would have been more apt, but because this is a risk they're taking, because we don't know what will happen. Suppose because once we started the IV, something goes wrong, like Sir was telling, then we won't have any answer, because
now previously it was altiplase where 1 hour drip was giving over a period of 1 hour. Now it is tenectase. We usually give within less than 1 minute. By the INR comes, we have no chance of stopping the drug in between.
Yeah, that's true.
So, Dr. Umair, do you do this in M2 also? Do you do mechanical thrombectomy?
Up to M2, sir. Up to M2, not be beyond that. Once it crossed the opercular the area, insular opera, we don't do. But we have done up to maybe M3. I have done one to M3, not beyond that. But we can put 1 milligram there, so maybe 1 milligram of the this tenectase 1 milligram or even 1.5 milligram. And most of the time, I had one medicology, one professor was there. He had a nephrologist. He came with acute straws with the M2 occlusion. So there is no way other than to help him, because the time window is already out, around 5 hours. So just put a microcatheter there and then infused this thrombolytics there, and improved very remarkably well. Remarkably. So many cases, not just one, many cases.
Hello, Meenakshi. Good evening. Welcome.
Meenakshi, apologies for the delay, sir. Got stuck up, sir. Very sorry.
No problem. Meenakshi, we have reached the point in the discussion where only your expert comments are required.
Not at all, sir. Because I was listening and learning, sir.
No, the thing is that this is Ramesh. Ramesh is my student only. And I think only my students can take such bold decisions. Because sometimes I tell my students have now become very prominent doctors. When they do something, I said, how did you do this? How could, sir, you only taught? Then I don't say anything. And when they don't know anything, they say, sir, we don't know, we blame you because you didn't teach us this. There's one of my students, Renu, in Delhi.
Sir usually says the guidelines are guidelines, not the guidelines.
So therefore, the brickbats or the bouquets have to come to me, and I accept them with a lot of love and pleasure. But Meenakshi, what Ramesh has done is that he has crossed the dotted line. The patient had an INR of 2.2 and he thrombolized, and patient did well. So now, please, at this point, I would want your comments.
I was hearing the discussion, sir. There is no way I would have dared if I had known the INR, sir. Not knowing would have been an easy option. But if I had known the INR, I wouldn't have done that, sir. It would be very difficult to convince myself to do that. We do a spot INR in the emergency. We have that with us. Whenever a patient is on anticoagulation, we do a finger prick INR and see. If it exceeds 1.6, if it touches 1.7, I don't do it, sir.
But actually, I have once become very stressed and I could not sleep the whole night because I did not remember, is it 1.7 or more than 1.7? Which means that if a patient is 1.7, can we thrombolize him? Or is it 1.8 that, but you are saying that if it touches 1.7, you will not touch him.
I will not touch.
So Ramesh, I want to know one thing from you. You must have reviewed the literature. Now, there are some cases where people have been thrombolized beyond 2.2, beyond 1.7. What were those settings? They were thrombolized inadvertently or knowingly they were thrombolized? I want to know from whatever case reports you went through. We'd be interested in that.
No, here there was a 2020. There was a case report, sir, where still INR was 1.9. They know and they given the thrombolysis.
Okay.
So patient did well.
Yeah.
Almost whatever literature says, almost 500 cases where INR is more than 1.7, still they thrombolize. So previously, I already told previously, altiplase was there, 1 hour injection. Once the INR comes, they abruptly stop in between. But now tenecteplase within less than 1 minute we give bolus dose,
And
there is no stopping of once you thrombolize.
And Meenakshi, I think you came a little late. We were discussing a very important topic, that we have seen that some patients develop a stroke in spite of supratherapeutic INR, means at 2.7 or 3 or even 3.5, they get stroke. And on the other hand, sometimes we find patients with subtherapeutic INR developing brain hemorrhage. So there is this problem with INR. It is not that accurate. What is your experience, Meenakshi?
Same thing, sir. Same thing. And in fact, I remember one of the trials called BAFTA trial, which looked into INR and stroke. What was happening? And anticoagulation. What it showed was that the administration of anticoagulation or this anticoagulant, they do not prevent the stroke. But if the stroke happens, it may be because of different mechanisms. For example, these were patients who were included with the atrial fibrillation. They were followed up. They underwent scan at the end of the 3.5 years, I think, duration. I don't remember the exact time. They underwent scan in the middle also. Even if they had not, if they had any symptoms in the interim period of 3.5 years, they underwent scan. Even if they don't have any scan at the end of 3.5 or 4 years of follow-up, they underwent scan. Interestingly, the scans, the serial scan showed multiple times there were subclinical infarcts in them, which told us that anticoagulation will not be able to prevent stroke altogether. The second interesting data from that was that many of these patients fortunately had only lacunar infarcts, which probably had mechanisms other than the conventional mechanisms of stroke which we are seeing, which may not be prevented by this. And even after that, if the stroke happened, it prevented a major stroke from happening for them. Probably the large vessel occlusion was prevented. The minor strokes happened irrespective of whether we do or not. That was one data I could often come to my mind, sir. The subtherapeutic INR and hemorrhage, I baffed in this. That's a googly, I think.
But I'll tell you. Yeah, please.
Sir, there is a long time ago, I had a patient, one doctor's father. He has come with a stroke, acute stroke. And we checked the INR, it was 1 only, just 1. I mean, he was not on any warfarin or anything. So discussed with his wife and told that he needs IV medication and all. They consented, but unfortunately, patient had a bleeding, intracranial bleeding, and after 2 days, he expired. So the son came afterwards. His son is a pediatrician. So he filed a case against me in the IMA. And there are many doctors, and actually it is in 2005 or something like that. So the whole IMA, they gathered and they asked me, why do you start an experimental drug to a patient?
What was that? No. Which experimental drug?
There is a TPA at the time, IV TPA. Why do you, this experimental medication? Okay. One new neurosurgeon was there and many other members, all people, many people are there. They're all exclaimed. And this fellow, they were telling that you should have taken an MR first. So MR should have been a CT. So I had to answer for 3 hours with a normal INR, not on anticoagulation, not on, probably he's on aspirin only, nothing. Otherwise, no positive bleeding or anything. So that is the issue. Sometimes they can land up in trouble. That is the only issue. Because we can convince any people that we can start on IV. We can convince. But something goes wrong, then some third person will come. And that the INR is this much, and that is the issue. But if you're too much in relation with the patient or relatives, then of course there's no issue. Otherwise, sometimes.
But Meenakshi, I was telling them that one of the things which, the thrombolysis indications have been so much relaxed. That means you can almost give it to everybody except probably a massive hemorrhage. I would not say hemorrhage, except probably a massive hemorrhage, because I have seen thrombolysis being done even when sulcal bleeds have been missed, and being given. But there has been no change in this platelet count of 1 lakh. It stays as a rock, this platelet count of 1 lakh. But we are not required to even check platelet. So I have seen some patients retrospectively after having received their platelet count was 75,000, 80,000. So these figures are to some extent for safety, but they're also arbitrary. I mean, there is not absolutely, they are not, but it is for the sake of patient safety and more than patient safety, our own safety, that we have to just maintain these. Otherwise the given patient may, like your patient did well, but that is not something which till it comes in guidelines or something.
One of my, same way one doctor came to us and he said, my father is on antiplatelet, so check the platelet count prior. So I had to convince him that these medications do not change the platelet count. They change the platelet functioning. It is not the count that is affected. But somehow he was not convinced. And we had to convince him, and then we left it to him. He didn't get thrombolized. So sometimes they really put hassles in front of us. Patient on antiplatelets, I mean, as sir was saying, sir, Dr. Umesh sir was saying, I have faced, sir, the same thing which he was facing. That when you are administering IV TPA, people have told that it is a wrong medication to give. And I shouldn't venture into it because our first IV TPA was 2003. And a few cases initially would obviously be successful. And once you land up with a bleed, then every blame game starts.
Yeah.
They
But
really,
Ramesh,
so these are not required. Why did you give?
But Ramesh, thank you for teaching us. You see, this becomes our experience that, this is experience. If a next patient to me comes, I may still be afraid. I may still not give him, but then it adds to my knowledge that, okay, once in a while, if it happens, it does not necessarily mean that the patient will bleed. And, so this adds to our knowledge. How do we know? I have seen previously people with 75,000, 80,000 platelets, they have been thrombolized. As I told you, I have seen patients with a sulcal bleed, which was missed. He was thrombolized. Patient did extremely well. But that does not mean that today I will give to a patient of sulcal bleed IVTP. I'll not do that. But it is part of my experience that this is what makes us experience. So thanks for sharing and, being open with us.
Very bold, sir.
Yeah.
Bold.
Yeah. No, he has talked to the family. The family has, they have taken the...
No, patient had a zero power and they thought she will be in the bedridden state. So let's do, sir.
Now, I'll tell you, there's one doctor's father who was given IV TPA many years ago, before tenecteplase came, and after TPA, there was no improvement. And the doctor's son was in US. In US, a lot of people use heparin. And he compelled our doctor, you give him heparin. My own friend, he said, no, there is no role of heparin. After I have given him TPA, there is no role of heparin. He said, no, you give it. I'm telling you, I am giving you consent. You give him. So my friend had to give him heparin after TPA and the patient improved. Then I requested that friend to present it in a meeting. He refused. He said, no, I cannot present in meeting. I cannot present it. So this is experience basically.
These are the experience. Yeah, experience. Yes.
Dr. Ramesh, you took a written consent from them, right?
Yes, sir. Written consent.
Or a video consenting.
Yes.
Because people can get nasty. So one of the reasons I'll honestly tell you why I got delayed, sir. I had prescribed oxcarbazepine to one of the patients. The patient has developed a rash. All my prescriptions of oxcarbazepine, they say that if there is a rash, you must immediately stop. The family claims that at the onset of rash, they have stopped. The child has gone for probably Steven Johnson or more than that, 10. Child is admitted and the child is now getting better. They came to fight with me last 7:30 onwards. They have been fighting with me, demanding money from me because I am the reason for the rash and the hospitalization. So I told them that I have taken consent from you. In fact, the consent was not taken, but fortunately, the case record which they have in their hand says that stop if it is rash, allergic rash, everything. But still, they can be nasty because if things go wrong, for instance, this patient has bled.
You'll be safe.
Yeah, but this patient, if bleeding has happened, they will blame you. So long things are going fine, they wouldn't tell anything. In Tamil, there is a saying called "Tappital Tappille." If you escape, it's not a mistake. That's all. So once the problem happens, that is when
proper video counsel and then written consent.
Always take a video consent and then you do it. Then there is no issue at all.
Yeah.
But this patient fought with me for 45 minutes fighting, sir, with me.
Oh, sorry.
And ultimately demanding money. That's the ultimate. I told him, if you come and tell me I'm poor, help me. I will ask my friends, I'll ask my hospital to speak. But you are demanding that I've done an error on my part, which I'm not going to give up. So fortunately, documented that rash will stop.
So yeah,
just a
documentation
lesson.
is very important. So I think we had a good discussion today, and thank you, Meenakshi, for joining at least in spite of the stressful situation. And thank you, Dr. Ume. Thank you, Ramesh. It's a nice session. So over to Ajinkya.
It's an honor to be with you, sir. It's an honor to be with you.
It's an honor to help you, sir.
It's an honor for all of us to be together, to talk, to learn from each other. Yeah. Sir.
Yes, sir. As usual, the workshop was truly amazing with an online view count of more than 100. And I'm sure our audience must have been deriving the immense benefits from this. And I would like to thank everyone for sparing some time from your busy schedules. I would like to thank and congratulate Dr. Makwana sir, Dr. Ramesh sir for their interesting case presentations. A special thanks to Dr. Kaul sir, Dr. Meenakshi Sundaram sir, Dr. Umer sir for their expert comments and valuable practical insights. So working under your guidance in future programs would be an absolute privilege, sir. With those closing remarks, we bring this session to an end. Once again, thank you all. Goodbye and good night.
Namaste.
Goodbye. Yes.
Yes, sir. Thank you very much.
Thank you, sir.
Thank you, Meenakshi.
Sir, Umer sir.